The Hair Transplant Network is the largest hair restoration community created by patients to help you find the best hair loss treatments and surgeons based on results.
Let's start from the top. I asked Dr. Bazanga because Dr. Kostis here, which you guys see his hair, had a hair transplant and he had chest hair transplanted to the top. Now, I asked Dr. Kostis whether or not he noticed any difference in his hair texture or in the length, because a lot of people have said, you know what, it's all about donor dominance. So the chest hair that you transplant to the top is going to look like chest hair and it's going to grow only as long as chest hair. But I've gotten conflicting information. Some people say no, it'll mimic scalp hair because you're transplanting it to the top. So, Dr. Costas, if you could kind of touch on that, what's been your experience with the chest hair?
We did it like as also like an experiment to see how they fit because the texture was similar. Contrary to my beard, like the texture of my beard is very coarse, so you could spot the difference very easy. But with the chest hair, I cannot even distinguish the hair. And when I told you before, when I'm going to the hairdresser, he cannot even himself do that. So that means that they blend it well, and you need to think also that a lot of times you blend the scalp hair with the body hair, so you will not be able to notice the difference. It matters, and also it gives you a better illusion of coverage at the end. But you need to be an expert, so you will choose for follicles that they are not in the telogen phase. So you will have like a growth, not in 5 years time, but like in six months to a year. So you need to know which follicles you will take, and of course you need to have a group of like experts around you, the technicians. They know how to extract, and so they will not destroy the follicles, because if you destroy the follicles, because the attachment is very different and the feeling when you are punching is different because the skin is very tough.
Mm.
uh, it's a completely different procedure than the scalp hair, so everyone has to do his part, so you will have an excellent result and to have the full growth. That's why a lot of people, they don't have the full growth because someone killed the grafts during the procedure at some point.
And that's a perfect segue because I wanted to ask Dr. Bazanga. Someone was on the forum and was saying, you know what, chest hair only grows 0 to 10% according to the literature. And so doctors who do chest hair, they're just taking your money knowing that it's not going to grow. And I thought one important thing is that, I remember a study back in, I don't know, maybe like a decade ago, where they studied FUT versus FUE. And the surgeon said, FUE grafts are skeletonized and they just don't grow. In my opinion, these studies only tell you what the results are at that particular clinic, not
Exactly.
industry wide. So, what has been your experience at your clinic, Dr. Bazanga?
Listen, in this field, unfortunately, you have a lot of people who work in the surgery and a lot of people who spend time just writing things left and right because that's all they know how to do. When you're doing surgery on day in and day out, you focus on your craft. You want to make sure that you master every step. You train your staff uh, to the fine details. And so all this crap about the FUT, FUE, for me, that debate is dead because we have excellent result with both FUT and FUE. I'm not a doctor who bash one procedure uh, like FUE or FUT. I think both technique, I've been saying that since 2005, both technique have their place in restoration for patient. So choosing FUT or FUE, it's a matter of expertise. It's a matter of knowing what you're doing. And FUE grafts are smaller, but it's not because they are smaller that they're not going to grow. I think if you have finer hair or finer graft, they do grow. Is the integrity of the graft when you place them, when you respect the graft, when you hold the graft properly, then you have absolute good growth yield. As far as chest hair growing for 0 to 5%, that's baloney. Because as I was, I've done a lot of body hair for the past 15 years. And as Kostis mentioned, chest hair is different than scalp hair procedure. Totally. The feeling of the scalp, the direction of the hair, the attachment, the way you handle the graft. All these are very important details that will make sure that you have a good yield or not. So if you publishing your study because you don't have the expertise of how to handle, then your study is just a bias study because it's just showing your level of expertise in that area.
Yeah.
So there is no reason why you should yield 5% of chest hair. There is no reason. This is not the experience in my clinic.
Yeah.
Now, everybody has his own experiences, his own expertise, but I think as a true pioneer in body hair, where, as I was saying, we were very few, less than 10 doctors back in 2002, 2003 doing it. So we understood what worked, we understood what doesn't work. And there's a learning curve. We knew that it was important to train your staff properly and not to rely on mercenary staff like most clinics do. So all that would dictated your result, would dictated your level of expertise. So I think that the debate should not be if you yield or not. I think people who need body hair is because they don't have enough donor supply in the scalp. So it's a good source, but make sure that you go to someone who knows, who have a track record of it.
So if I was a patient and I said, look, I only have chest hair, I've exhausted my scalp hair, I've exhausted my beard hair, what would be the percentage you would say at your clinic that the chest hair would grow? If you had to give an approximate guess.
I think for the chest hair, we are between 80 to 90% with no problem.
Wow.
I just don't want to say 100%.
Yeah, of course. It's never going to be 100%, not even with scalp hair. There's going to be some hair that doesn't grow, but
but from my experience, we put a lot of chest hair into the scars and all that for FUT scars, scalp reduction scars, and people coming are very happy. So if it was not the case, people would not come. We will have people complaining that they didn't see any yield of and we are very concerned when there is no yield. We want to understand why.
Yeah. We have a question here that came into the chat. Is atopic dermatitis contradictory to getting a hair transplant?
No, I don't think so. Obviously, when there is inflammation, is not a good environment for the graft to grow. So if someone has atopic dermatitis, you can treat them prior to the surgery. And I've done some patients with really serious seborrheic dermatitis. When we shave the scalp, they're full of it, but we treated along, and they had very good result after transplant. So Yeah, it's good to see the patient before to put them under treatment. And but if you have a patient flying from Hong Kong and coming, and so explain to him that inflammation is not really the good environment for the follicles, but we need to make sure that we treat it and we keep it under control.
What, and I had a really, really good question come in, and it's something that I think I've kind of contemplated myself is it possible to harvest so many grafts from the donor that you slowly start to make everything blend? So let's say you're Norwood 6 and you want to kind of make the entire scalp look a little bit thin, but get more coverage, and just so that there's not that horseshoe appearance. You know, the problem with strip that I think that, and is that because it took it from a linear place, you always saw, no matter how many grafts you transplant, you always see that horseshoe pattern, no matter what, because there's still going to be a difference in density. But is it possible to kind of transplant even density throughout the entire scalp so that maybe the entire scalp is around 40 to 45 grafts per square centimeter? What do you think?
Yeah, let's do just a pure math.
Yeah.
If you have an average size of head, let's say around 200 square centimeter of molding surface. If I take your theory of planting 40 follicular unit per square centimeter, you need 8,000 grafts. Most donor cannot give you 8,000 grafts, regardless if you take up or low. So that's why people have to be realistic. 40 throughout the entire scalp with hair restoration may require you to have an exceptional donor or the use of body hair.
Yeah.
Just by taking from the scalp alone, you won't be able to achieve that. So another thing is, most patients are younger patients. So when they start the surgery journey, we try to avoid taking hair closer to the margin of
The
Norwood
demarcation
6
line.
on the fringe,
Yeah.
because we know that the hair loss will progress. So I may take 1,000 grafts along that, but if I know that in 2 years or in 3 years your hair loss will continue, so you pay for graft that will really not going to be there.
Mm.
So what we do with patients really have to make sure age matter. If I have a 40 years old man that I have done 2 or 3 surgery before, then he come for, let's say, another 3rd or 4th surgery, yes, I'll be inclined to go and harvest more hair around that fringe to thin that area out so that they don't have a lot of hair sticking out, because we have harvested most of the hair below. But doing that, I always mention to the patient, it's good to be on medication so that your hair loss do not drop further down. And even that, there's no guarantee that if we take the hair from there, if they will be there 2 years, 5 years from now. So we
Absolutely.
really have to make sure that we understand what we're talking about. You know, as of today, if someone wants a full total coverage, you're going to need 16, 17,000 grafts. Because
Yeah.
just the crown by itself is a dead hole, because it just swallow a lot of grafts. So if you want a good density in a crown, you may have to, if you have 100 square centimeter in a crown, you have to place 4,000 or 5,000 just in a crown
Yeah.
to have a
That's,
good coverage. But that maybe most people, that's all they have in a donor.
yeah.
And then let's talk about body hair. When you place body hair, most body hair are single hair. Very few people, if you go to India, Middle East, some of my Greek friends, Kostis, they may have
Yeah.
a lot of 2, 3 in the body hair, but
Yeah.
most patients up north do not have a lot of hair
Yeah.
per follicle in the body hair. So most of the body hair will be single hair. So that means you need even the double or the triple of the amount to get coverage. So where you place 4,000 scalp hair, you may need to place 8,000 body hair for you not to see the skin, because most patients come and have this idea that I'm doing the transplant, I don't want to see the skin in the crown. And I always tell them, I'm going to transplant graft, but I'm not going to promise that you're not going to be seeing skin,
Yeah.
because that's not the goal of a hair transplant.
Not
especially in the
realistic
crown.
either. Yeah.
Yeah.
I
So I
think
think
those are.
crown surgery is the most challenging part, because it just takes so much. And when you have younger patients who come and they only want to start with crown surgery while they're feeling both in the front, on top, and the crown, I usually say, listen, you really have to rethink your priority around, because it may not be the good idea to start with a crown restoration.
Yeah. I agree 100%. I think for anyone out there watching who's like a young person who's starting to see hair loss, the number one thing that you need to do is preventive medication. You know, you need to prevent that. If you can stop from your crown from thinning, you've won half the battle. You know, the crown, once that starts to go, I mean, you're kind of facing an uphill battle there. I think that someone asked about oral minoxidil, and I know that you're one of the leading surgeons who's been, prescribing oral minoxidil. And before you, honestly, I hadn't even thought about it. And once you started talking about it, it seems like everyone's kind of been like jumping the bandwagon and getting on oral minoxidil. Someone asked, what is the protocol that you start your patients with? Do you start them off on a low dose and then move them up? And what are the type of side effects that you're seeing at your clinic, if any?
First of all, if you compile the literature, and there is a doctor in Australia, Dr. Sinclair, who is a leading really dermatologist who did a lot of research on oral minoxidil. There are very few side effects when you start men with 5 milligram dosage. And women will start with 2.5, but we usually combine women with spironolactone, that's an anti-androgen, so that helps also to minimize a lot of unwanted hair. Very few patients will complain about chest tightness, so they will say they feel like, or they will feel like they're lightheaded. Some will say they feel puffy eyes because of retention, because minoxidil is a vasodilator, so they feel a little bit of retention, edema, but that's a very few percentage. Most of those patients, you find out even when you put them on topical minoxidil, they still have the same side effect. So if they experiment that, we ask them to cut a little bit the dosage, instead of starting with 5 milligrams to go to 2.5. Some will try, some will just say, listen, I don't feel comfortable with my side effect, and I'll stop. But so far, it's an overwhelming experience of, I didn't expect that when I started, because I came across some lectures by Dr. Sinclair and Dr. Sergio Vagno in Madrid. And so I started using it, and I just, first of all, I also switched because of myself. I started using it, and I see, wow, it was working on me. And so I started just randomly giving oral minoxidil, but the overwhelming reaction for patients who had been having surgery with me for the past years, they're questioning if they will stay. They becoming closer to their 50. They don't want to stay on finasteride for erectile dysfunctions and age and all that. So I said, listen, let's switch it and put oral minoxidil. And they saw just, wow, the hair is just even better than they used to be on finasteride for 10, 15 years, and they see that the result is much better. So that's why I personally got convinced, say, I should prescribe it as a first line of treatment because, if you have a patient in a consultation, when you talk to them about finasteride, the first thing they will point to you is the post syndrome.
Erectile. Yeah,
the post syndrome. They will see this website, the Foundation for Post Syndrome Finasteride, and all that. So it becomes almost a difficult consultation. While you know that it's a young patient, he needs to be under medication. And in the other hand, he doesn't want to take it for obvious reasons. So oral minoxidil has changed the way we do consultation in hair transplant, at least in my practice. I do prescribe it a lot, and very few people have really serious side effect. And so 5 milligram for men is what we advise, and for women, it's between 1 milligram to 2.5 milligram. We add spironolactone. I have a compound pharmacy who can do that, and we can ship almost around the world. So that's work well for us.
What about when people, I'm going to be asking this kind of for myself, so what about when people say, well, how do I get oral minoxidil? Let's say if they're not from like Belgium or something like that.
They can consult with us. We do online consultation, and then we can prescribe it and point them to the compound pharmacies. We can ship it actually almost everywhere in the world. There are very few countries that do not allow medication to come in, but even in Canada, with the prescription, there is no problem at the custom. But that part is handled by the pharmacist. I have no bearing. I have no responsibility.
But for the oral minoxidil,
for the oral minoxidil, we can point you to the right pharmacist. Yes, but in order for us to in order for us to do that, you have to consult with us. We have to open a file and all that. Just check, make sure that you don't have any health conditions that will require us for you to go see your cardiologist before starting the medication.
We're gonna have to have a conversation after this because I need it. It's been difficult to get here. So,
but it's because most doctors are not familiar with the prescription of oral minoxidil, and they feel uncomfortable prescribing it.
That's it. My experience has been most doctors here say it's unsafe because of problems with your heart, and they just don't want to.
When they were giving oral minoxidil, they were giving 100 milligram, 50 milligram for high blood pressure. We're giving 5 milligram for
it's completely different. And what's your views on what is the best preventive stack? If because I've always thought like I'm having a baby. I'm having a baby, and I think if I have a son 20 years, 22 years from now, he starts balding. The first go-to I'm going to say is topical finasteride. I'm not even going to mention oral finasteride because I really don't think that's even worth it. I mean, there's too many side effects, too much risk. Why even waste time on the oral version, in my opinion? But then, you get the oral minoxidil. So what would you say is the best stack? I know you have some sons. If they were saying...
There is no, this should not be a matter of dogma, say there is the best. I think you have people who respond well to minoxidil and people who respond well to DHT blockers. So for young patients now, the consensus, at least with the group of the Spanish doctors, Dr. Vano, I think oral minoxidil with dutasteride is the first line of treatment.
Mm.
Now, dutasteride, you can also have it in a gel form instead of tablet.
Yeah.
So I usually prescribe minoxidil tablet and dutasteride gel. For those who can come to the clinic, we can even do mesotherapy with dutasteride, where we inject dutasteride every 8 weeks into your scalp, so that you don't have to take it by mouth, but you can have it injected into the scalp. And we've seen some amazing result with that. Finasteride, most of the time, is just you feel resistance from patients because of everything that they will read online. So it become almost useless to try to convince them to take a medication, because this is a lifelong medication. I usually tell the patient, when you start it, it's going to be for a long haul. So you can't just take it on and off like you're taking Tylenol because you have a headache. You really have to commit to it. And so you need to understand the medication. You need to make sure that this is what you want. I had hard time convincing Dr. Kostis to take the medication.
To take it, really?
But now that he has taken it, and you see even the effect on the remaining hair that he had in the crown, and so I think he can testify himself.
Yeah, Dr. Kostis, what has been and someone asked in the comments if I had a hair transplant. Yeah, I have had a hair transplant. And looks like everyone here except for Dr. Bisanga has had a hair transplant. Dr. Kostis
not yet, not yet.
Not yet until maybe Dr. Kostis will get his hands on it.
I still maintaining
He's still maintaining
with medication.
So, Dr. Kostis, you were a little bit apprehensive of starting medication, like many of us are, right? Especially if you read the horror stories online and you're like, no way, Jose, I'm not gonna get touch this stuff. So after Chris convinced you, what's been your, well, number one, what are you taking? And then number two, what's been your experience with the medication?
Okay, first of all, you need to know that the most difficult patients are doctors.
Oh,
it's
yes.
very hard. Yeah, it's very hard to
Absolutely.
convince them to take anything.
Yeah.
But look, I start to take oral minoxidil 5 milligram, exactly after my surgery, and it gave an impact not only on my native hair but on the transplanted. So I had an early growth, like when I was like 5-6 months post-op.
A question now.
I had an amazing result because I was looking like a week ago the photos like 5 months after, and I said, wow, it seems like a year, but it was only 5 months. So I was consistent, and I see a difference in my donor area. Also, I feel that I have very fine hair, but with the medication I have the feeling that they become like a bit thicker, and also I have the same feeling on the top of my head and on my beard, I have to say.
Wow.
So I had a very good impact regarding the oral minoxidil. I never tried before anything else. So I only started with oral minoxidil, and we will see as the years will progress, and I will see like where my hair loss will stop, because now I don't see like any hair on my pillow or while I'm washing like in the shower. So hair loss has been stabilized, and except that I see that the quality of my hair like is even better than it used to be.
Guys, what do you guys say about someone who will say, well, oral minoxidil is only a temporary thing because you're not the DHT is still going to be attacking the root of the follicle, and so you have to have an anti-androgen. A lot of people will say this. What are your thoughts on that?
Listen, there is more to the hair loss than just the anti-DHT or the DHT theories. I think people lose hair because there is inflammations. People lose hair because they may have some chemical imbalance. Stress is a good cause. You see now with post-COVID, you have a lot of telogen effluvium with a lot of loss that some are not recovering. And so I think when it comes to hair loss, DHT is just one part. There is other part. So otherwise, if it was just the DHT theory, you give everybody dutasteride that block alpha 1 and alpha 2 reductase enzyme, you block all the DHT, all the patients will have all the hair back. But we know that in reality it doesn't happen. So then there is more to the DHT theory when it comes to hair loss. I think it's a combination of a lot of factors. So when we put people on minoxidil is what we call anagen stimulator. So it's going to probably push more hair to go into anagen phase. So that's what people want to see. They want to see healthy hair. And so I don't think me personally. I don't take finasteride. I used to take it. I stopped, and since I stopped finasteride and moved to minoxidil tablet, I have better hair quality than I used to have when I was under finasteride.
Wow.
So that's why I say, from my own experience, that there is more just than the DHT theory. Merck's made a lot of money with Propecia because of DHT theory, but I think there are more and more. So with the coming years and the knowledge that we're seeing today, with all the stem cells and everything, I think we will see that there is more and more. So DHT will be just one part of the equation, but there are more other things that need to be added, and for the sake of patients. So yes, don't be afraid of thinking that you should only use finasteride, but I'm seeing good results just with minoxidil tablet, and I think it's safe. Most patients say, "Yeah, we want to start a family and all that." I say, "Stay on minoxidil."
Yeah, I think you bring such an interesting point, and I think that you're absolutely dead on with the DHT theory. That's only one aspect of hair loss, right? This is why the big three is the most effective, right? Because the big three, you're attacking hair loss from every angle: scalp inflammation, DHT, shortened anagen growth phase. That's why it is the most effective. DHT is only one part of hair loss. So I think that's super important, and I think in the future we're going to see a lot more treatments that are treating different aspects of the hair loss. So absolutely, that is dead on. I wanted to ask you guys about something called I'm going to try to pronounce it. Verdaporphin. Have you guys heard of this? Verdaporphin?
No.
You ever heard? So verdaporphin is something that's being developed for the development of scars. We actually have a guy who just joined here. His name is Follicle Thought, who wrote an article about it. And it's basically, the theory is that it could potentially heal scars, so you would have an unlimited amount of donor. Now, I don't know how much there's truth
You
there is
cannot
to this.
you cannot have unlimited amount of donor because you heal scars. Because when you take hair from the scalp, the hair is gone. Yes, there is a scar that is remain. You heal the scar, but the follicle is not back. So you cannot say you're gonna have unlimited donor, because it doesn't create any regeneration of the follicle in a donor, if I understand correctly. Because if he heals only scars, it doesn't regenerate the follicles to say that is unlimited. I think we all want to have unlimited donor. We all, but as of today, 15th of July,
22.
2022, there is no such a thing as unlimited donor or a treatment that will be proven to give unlimited donor or give a full regeneration of the donor, because there are just a lot of things that we still don't understand completely when it comes to the hair follicles and everything.
Yeah, I think I think I was optimistic. I think we need to know a little bit more about this. I'll send you. There's actually a doctor who's doing a study, Dr. Barguthian from Jordan. He's actually doing a pilot study with his patients to see what happens. I mean, if anything, worst case scenario.
Send the study. We'll look at it, and why not? I'm always open-minded to see new things, but also I've been around for long.
Yeah.
To know the trend, and people being put ACL left with open wound with a strip, and they put ACL in it saying they will have no scar and end up with 2-3 centimeter scars. So I'm always very cautious because because I've been around and I've seen a lot of trend come and go, especially in the hair field where people are desperate. Our patients are desperate, so they are ready to believe a lot of things. And some of our colleagues will just push the envelope for desperate people so they can get a little bit the patient out the door. But I think that's the problem in the industry. And we're giving treatment that we're not even sure that is working because patients are so desperate and they're willing to pay for it. So, as I say, I'm always very cautious because I've seen a lot of this trend for the past 20 years. So, when I stick to things that work, is just because if it's not broken, don't fix it.
Yeah, no, I agree. I wanted to ask you guys about two things. All right, so someone asked, what is leading to this early growth that you seem to be getting, Dr. Bisanga? Because BHR clinic just in general has been, patients start to see a lot of growth by 6 months. And, Dr. Kostis alluded to, when he got on oral minoxidil, his growth he started to see like more growth. So is that something that might be helping you guys see early growth?
No, I think it's a combination of different factors. Over the years, I changed my protocols to try to manipulate less the follicles and to minimize time outside the body, and but also training my staff myself and spending hours. I have staff that placed graft for the past 18 years. I still come and look over their shoulder to see what they're doing. And so I think it's a combination of, it's not micromanaging, but it's really making sure that the follicles is intact from when we punch it, how we harvest it, and how we plant it. I usually tell my staff, because I like them to harvest the follicle in a 3-step technique. And so they hold the follicles, they hold it, and then they pull it. But sometimes they say, yeah, but it's coming easy. I say, I don't care if they're coming easy. I want you to keep the 3-step technique. Why? Because when you just yank it like that, like you see on the internet, a lot of people yanking the follicles.
They're just like,
some of the stem cells that are around the follicles are staying because you just rough. A follicle is a delicate structure, so it has to be treated gently. And I think one of the things that differentiate most of our protocol is that part. I don't rush. I tell patients when they ask me, doctor, when are we going to finish? I say, I don't know. I know when we start, but I don't know when we're going to finish, because
Yeah.
it's never in my mind to rush anything. You can come for 300 grafts. If it's going to take me 6 hours, because even if it's 300, because your case is difficult, you're going to get your surgery in 6 hours.
Yeah.
Because we want to make sure what matter is to have an intact follicles with all the structure around it. And then when we go to microscope, we sort the graft. We make sure that all the good grafts are put on one side, the graft that is a little bit the dent on, separate them and all that. So we make sure that whatever we plant will grow.
Yeah.
The handling of the graft during the placing is also a crucial part, because you can have all the good graft, but if the person who's planting them is not planting them properly, is not taking care, is not holding them the way he should, then most of the graft would die there.
Mhm.
I
Yeah.
see. I've been to a lot of workshop where you see graft almost dry. Me, I always tell my team that my graft, they are like fish.
Yeah.
Fish live in water, here in
Yeah.
saline solution. So we make sure that I like to see them floating. Some
Yeah.
technicians have an aversion of having the graft too wet. So they want them dry, because it's easy for them to manipulate them when they're placing, because they are all in a rushing mode. So they want
Yeah.
to have as little as possible. But those grafts are vulnerable
Mhm.
once they dry. So it's a combination of a lot of things. I have placed a lot of grafts myself. So that's also a difference. I have placed grafts. So I know how difficult it is to place grafts. A lot of doctors don't have any clue how to place grafts. They never place any graft, any single graft in their life. So
Yeah.
they have no idea uh, how to make a good incision, so to make sure that the graft fit in without a lot of trauma and all. So I think it's a combination of a lot of things.
No, I think absolutely. I think it's a combination. I think the fact that you have that three-step process to remove the grafts, wow, that's the first time I've heard of that. And I think that's a game changer. I think that's definitely one thing that I've seen consistently with you guys is that the growth comes on so quick. It's like, my God, I'm almost like, this is setting an unrealistic expectations for some people, because it's growing
We
like right away.
we don't market ourselves like a fast growth clinic or whatever,
Yeah.
because there are so many gimmick people can use for
Yeah.
marketing. To We just do whatever we do, and if our patients benefit from it, then we're happy. But we don't set the bar saying they're gonna have good growth at 3 months. We still have that protocol that say at 6 months you should expect 50%. But I know
Yeah.
for now that most patients are 50 at 6 months, they have more than 50% already.
Yeah, no, I agree. And you guys haven't marketed yourself this way, but I have to say, I've been sort of marketing you guys this way as the blonde guy hair transplant place. I mean, on the forum, there's like, it's like blonde guy after blonde guy after blonde. I mean, you guys are just absolutely killing it. I don't know. You guys recently went to Norway, what, like 2 weeks ago?
Yeah.
I feel like a lot of these, Nordic guys are coming to your clinic, and you just get it right. And these are difficult cases because, number one, they have very fine hair, very, very fine hair. So it's not always going to look as dense. But I mean, you guys, maybe you can touch on that. Like, what, you and Dr. Kostis, like, how are you guys able to get this right? Because I've told so many guys that message me, they're like, I'm from Norway or I'm from Sweden. I need what's a good clinic? And I'm like, look, honestly, Dr. Bisanga, and I point to the results and I'm like, this is like, I don't know where these guys are from, but they're somewhere from, Scandinavia, and they're getting fantastic results.
So I think um, hair is a hair. So you have to have an intact, first of all, an intact follicles. Second patient has to be a good candidate. A good candidate, it doesn't mean that they have to have thicker Greek type of hair like Kostis, who is not really having the type of Mediterranean hair.
That didn't get
But,
to him, huh?
Most of the Nordic patients, even though they have finer hair, but you'll find that they have 1, 2, 3, 4, even 5 hair follicles. Even though it's very thin, you just keep the consistency of the same thing, the same protocol. Make sure that you don't overdo it, you don't overkill it, because most of them also remain very red after surgery. So you have to make sure that you don't do too much in terms of density, because then they will stay. I have patients sometimes in the past, they stay really with an erythema for almost a year.
Wow.
So it's a combination of all these factors that I think we have come as a clinic to understand, because we are in the center of Europe and we have patients from all over. So we kind of have understood that they have a specific need for a specific type of hair. And so, it's one thing to have all this good 3, 4, 5 hair type darker hair that everybody say wow, but when you have those finer hair and then you have to work around it, it's a humbling experience. Sometimes you punch the follicle are so short. Most follicle when we punch, they are okay around 2.7, 3 millimeter to 4 millimeter. But some of those Nordic patients, they have a follicle of 1.5, so they really very tiny.
Wow.
So you have to handle them properly. You need to, so you're not there like in a machine, in a hair mill type where the only thing that matters is for you to punch. No, you look at what you're punching, you adapt, and I have some senior technician, when things are a little bit difficult, I'll say, okay, come here, because they've been through this before than the youngest one. So it's a combination.
Yeah, I've just been noticing on the forum that it's like you guys have become the what would you like I don't even know how to what I would call you guys, but just like the Scandinavian guys. You guys just been slaying all kinds of scalps in Scandinavia. I mean, you've been restoring scalps all over, and it's just incredible to see. I wanted to ask Dr. Kostis, how long ago did you have your surgery? Was it past a year?
1.5 years ago.
1.5 years. Can you move it? Let's take a look at your scalp here, because it looks. I saw you in February, and I have to say it looks way thicker now than it did in February. I mean, that's incredible. And Kostis is Greek, but you didn't get the thick hair. You're not a thick hair Greek guy. You've got the really fine hair.
Yes, the texture is like that. They are very fine. With Minoxidil now, they are even better. So, because I had also fine hair crease, I need to do the incisions very tight. So, the illusion of coverage would make the result look as it is now.
Yeah, it looks absolutely fantastic. We had a question earlier who said, how long does shock loss take to resolve? Like if someone they're 5 months, they still have shock loss, how long would it take for shock loss to resolve?
Shock loss, it depends. Some patients, the shock loss is going to take 3 months. That really the telogen time. And so most patients, we ask them to apply minoxidil, topical minoxidil, and usually it works.
Yeah, because I think with the thing with and I'm speaking for donor shock loss. The thing with shock loss is that you have to consider 10% of your hair is in the telogen phase before surgery. And then you get surgery, you remove a lot of hair follicles, and then you shock some of those. So it can take a little bit longer for you to start to see, some of that hair grow back in the donor specifically. In the top, I think 3 months, but in the donor, I think it can take maybe 6 months. What do you guys think?
I don't think I've never seen really a shock loss that lasts that long. 6 months, I think it's a long time. When you harvest hair from the scalp, you don't want also to take all the good hair, because
Yeah.
what happened also is is a split of a second decision to decide what hair do you take and what you leave. But sometimes people are just in a rush and just punching without thinking. You can just take, if you have an area where you have 2 hairs, then you have the 4, and then you have the singles, and you just decided to take all the 4 and leave only the single hair. You're not really giving a patient a service, because what you leave a donor that you look thin in certain areas. Some patient may consider that as a shock loss, but it's just the way that the harvesting protocol was. So that's why when we talk about the educated pattern of harvesting, is making sure that every single detail counts. How am I going to leave a less footprint on that donor, but by maximizing the amount of follicle that I'm taking, but by understanding that this patient is a young patient, is may need subsequent surgery. So it's always a balance act. So that's why you don't see me doing the 5,000 and all this, because most of these cases destroy the remaining donor. I haven't seen any 5,000 cases that when you shave them, that it looks good. Most of the hair will be telogen hair, and they will be shock hair, vellus hair, probably because of a conjunction of a lot of injuries. Because when you have to take such an amount, you have to harvest your hair very close to each other. So you probably destroy more blood vessels. You creating an area where there is less blood supply to the remaining follicles, and some of them will just go into shock and just grow as a vellus or miniaturized hair in the donor. So that guy that you take 5,000, if you have taken 3,000, you'll be able to take another 3,000 or 4,000 later, and you could have had a good surgery of 6,000 grafts. Now the 5,000 is all they got, and God forbidden if the yield is not good, then the donor is completely destroyed. Nothing will give you a better result than scalp hair.
Yeah, without
So
a doubt.
that's why we treated scalp hair with care. We make sure that every single hair we're taking in a donor, we try to leave the least footprint, because we don't want to mess that patient future hair transplant. We have a lot of repeat patients. Some clinics don't care, because they will
It's
see you
just,
once and that's it.
that's it.
So
Now you're
let them
someone
take,
else's problem.
yeah, let them take whatever they can and maximize, and that's not their problem.
Yeah.
But for a clinic like us, where 40% of patients are repeat patients that we have done over the years, you can't just take things casually like that.
Yeah. No, absolutely. I agree. Well, I've taken enough of your guys' time with the whole fiasco. I just want to apologize to both of you guys. I know it was not ideal, but I think that this was very, very educational. Just before I let you guys go, let the audience know how they can get in contact with both of you guys. So both of you are practicing at the clinic in Belgium.
Yes, we're practicing in Belgium, and Dr. Kostis is licensed also in Greece. So to contact us is really info@bhrclinic.com, and that will be the easiest way to get in touch. For those who are on forums, they can contact Ian. He goes by Raphael or Steven at BHR Clinic, and so that should be the easiest ways. But info@BHR Clinic is the easiest way also to reach us.
And are you guys going to be doing any consultations anywhere else soon?
I'll be in Maryland, in Frederick, Maryland, on the 28th, I think the 29th of August. So get in touch with get in touch with Ian.
Okay.
Because my family live in Maryland, so I still do some consultation in Maryland. Yeah. And so I have 2 full days of consultation in Maryland.
Perfect. All right. Well, thank you guys. Thank you, Dr. Kostis. If anyone wants to get a hold of you, how can they get a hold of you in particular? They want to ask you a question.
Through Instagram or through my email, they can easily do.
Okay.
But also through info BHR Clinic, always they forward the emails that are related to me, so I read them daily. So it's also an easy way.
Perfect. And just for you guys that don't know, his Instagram handle is @ilfuser. And don't forget to follow @Bisanga Hair Restoration. Thank you guys so much. Again, apologies for the technical issues we had earlier, but this was always a treat to have you guys.
Thank you, Melvin. Did we answer all the questions, or there were no other questions? Just make sure.
I believe we answered all the questions about, and someone asked about whether topical minoxidil or oral minoxidil is more effective, but I think that you made it quite clear. Oral minoxidil is by far more effective than the topical version. So yeah, I think we got all the questions answered. For anyone else who wants to ask Dr. Bisanga or Kostis a question, again, info@bhrclinic.com, or you can send them a private message on Instagram @Bisanga Hair Restoration or @ilfuser. Question just came in here. I had a poor procedure resulting in mild but visible cobblestoning. Will dermabrasion or laser treatment reduce flattened bumps at all?
That they need to go see, first of all, a doctor who does either dermabrasion or laser to make sure that, because sometimes patients call cobblestone, or it's just pure scarring from poor surgery. So you have to make sure that, first of all, that the diagnostic is correct. And then if the diagnostic is correct, then the treatment is different. So that's I've seen a lot of patients say I have cobblestoning, but when they come, it's more just scarring and pitting from poor placing and poor surgery. So I've learned to be careful naming things. Really, yeah. So if they go see a good, depend where they are, they can go see a doctor who's knowledgeable, recommended on this site, that they can get the answer.
Yeah. I think it's always important to do an in-person consultation. Again, Chris and Kostis are in Belgium, but I believe you'll be able to consult with Chris at the end of August in Maryland.
And then we'll see. Probably we'll come to the West Coast, but I'll let you know when I'm coming to the West Coast for consultation.
Awesome. Yeah, when you come to
I love LA.
Coast,
I love LA. So we'll come.
I can't wait. The door is open. We'll do it. We'll do an Instagram live, and we'll do a podcast at the new studio, not this past one, but at the new studio, and it'll be awesome. Thank you guys again for your time. Again, apologies, but this was fantastic. This will be saved. So thank the community and everything. Talk to you guys later.
Thank you, guys, and thank you for sticking around despite all the technical glitch. But we appreciate it, and stay safe and have a nice weekend.
You too. Bye-bye.
Take care.
Bye.